Good morning. I'm very pleased to join you at your grand rounds at the Miami Neuroscience Institute, and I wish to thank Dr. McDermott for the kind invitation. I'm Michael Failings, Professor of Neurosurgery from the University of Toronto, and I've had a long-standing passion in the treatment of acute spinal cord injury with a particular focus on the mitigation of secondary injury, and we've done a number of studies to examine the role and timing of surgery for intervention in this condition. Again, many thanks and appreciation to Dr. McDermott for this invitation. I have no relevant commercial disclosures. We do have grant support from a few agencies with funded work that I'll be discussing. I do, however, have a number of acknowledgements which are listed on this slide. Dr. Jatan Badiwala's PhD work is encompassed in a number of the studies that I'll be describing. And I also want to thank Drs. Grossman, Geisler, and Bracken for their collaboration. This is where I work in Toronto at the Criminal Neuroscience Center, and hopefully as the COVID travel restrictions ease, you'll be able to visit our center. And I have a wonderful team of people that work with me, and this is a photograph of the team, and I wanted to just to point out a couple of individuals. So the young woman in the foreground is Barbara Turnbull, was at the time was a C2 tetraplegic individual, and sadly has died of complications of her cervical spinal cord injury. And to my right and to your immediate left is my mentor, Professor Charles Tatter. So here's what I'm going to talk about. I'm going to review the clinically relevant pathobiology of acute spinal cord injury, and I'll talk about the rationale and evidence for early surgical intervention for spinal cord injury. I'll discuss the current AO Spine guidelines for acute spinal cord injury that our group was instrumental in leading. And I'll talk about novel data on the role and timing of surgical intervention for acute spinal cord injury. And some of these data are now in press in Lancet Neurology. I'll revisit the concept of central cord injury, which was previously thought to be a benign entity which should be managed non-operatively, and I wish to challenge that concept. And I'll provide some conclusions and some take-home messages. And here are the key learning objectives. So at the conclusion of my talk, the learner, I hope, will have a working knowledge of four areas. So one is the pathophysiology of acute spinal cord injury. Secondly, relates to the guidelines around the role and timing of surgery. Thirdly, awareness of new knowledge supporting the concept of time as spine. And then fourthly, an awareness of some of the current knowledge gaps and future challenges. So here are three different case vignettes. And spinal cord injury is heterogeneous. One needs to ultimately develop a personalized medicine approach to manage patients. So here's a person with a thoracic spinal cord injury, 45-year-old woman, T6 burst fracture, Asia B with sensory sparing. In the middle panel is a 39-year-old man with a diving-related C4-5 fracture dislocation and an Asia A cervical spinal cord injury. And C is a patient that presents with a traumatic central cord injury, 50-year-old woman, a low-velocity fall. She has an Asia C central cord injury type of picture. So traumatic spinal cord injury is one of the most devastating injuries that can beset a human being, and it's related to the eloquence of the cervical spinal cord. 2/3 of injuries affect the cervical spine, and this area is, of course, particularly eloquent and results in profound deficits. So if we look, for example, at the patient that I described earlier, who was a patient I treated in my practice. So here's this person, C4-5 fracture dislocation, a severe contusive and compressive injury. If one looks at the T2 weighted MRI, you can see that there is spread of the T2 weighted signal changes within the cord, rostral and caudal to the injury. And this represents what we refer to as a secondary injury. Now here's a post-mortem image, fortunately not from this patient. This is a slide that was given to me by Wolfgang Rauschning from his collection, but a very similar injury, a fracture dislocation, cervical spine. You can see the horrific primary injury that occurs. But there's also evidence of secondary injury. There's ongoing compression of the spinal cord, and there's clearly a contusive injury, and there's this area of hemorrhage. So if you look at this area in animal models, and this is a work that I did while a PhD student in Charles Tatter's lab. This is a cross-section of the spinal cord. And this animal has received an injury of the cervical spinal cord, and we injected the blood vessels with colloidal carbon. And what this illustrates is a disruption of the central vasculature, and there's a hemorrhage around this. So this represents the primary damage to the spinal cord vessels. But surrounding this area is a lucent area. This is the zone of pallor. And in this area, the nerve cells are ischemic. And if you study these nerve cells with confocal imaging, when the nerve fibers have been labeled with a fluorescent dye that marks the neurofilament proteins, you see that there's a progressive degradation of these nerve fibers. And this is referred to as a secondary injury. And this ultimately culminates in the pathology of a chronic human spinal cord injury, where the hemorrhage is resorbed, and you're left with a cyst where the neural tissue has been lost, and this is surrounded by the surrounding glial scar. And the concepts of a secondary injury are illustrated in this slide. So we see that initially there are the vascular events that occur. There's a reduction of blood flow, there's vasogenic edema, and coinciding with this, there are ionic shifts that occur within the cell. So there's a loss of the sodium-calcium gradients, where sodium and calcium go into the nerve cells. There's a release of neurotransmitters. This evokes secondary inflammation, and there's ongoing apoptotic cell death. Some of these events occur very early, within seconds, and many occur within hours to days. And it was these early events that intrigued me from the concept of trying to mitigate these with either pharmacological approaches or potentially surgical decompression. So there's a strong rationale to consider early surgical intervention if we consider the pathomechanisms of primary and secondary injury. So there's the primary injury, there are the mechanisms of the secondary injury, and then the hope would be that with early surgery, what might mitigate some of these secondary events. And indeed, in this elegant meta-analysis of preclinical studies of early decompression acute spinal cord injury, Peter Batchelor and colleagues from Australia examined 79 basic science studies and found very clear evidence that surgical decompression in animal models results in improvement in outcomes, and that the effect size is closely related to the duration of compression. Now, how early is early? And this is a challenging topic, and the knowledge for this is evolving. In a systematic review we undertook about 12 years ago, the 24-hour cutoff was most commonly used in 9 of 22 clinical studies. In a survey of almost 1,000 surgeons around the world, the vast majority preferred to decompress the spinal cord within 24 hours. So it seemed that there was a clinical sense that 24 hours represented a critical cutoff. Now, our group has led a guidelines effort, which I'll summarize in a moment. These are the systematic reviews and the guidelines articles that emerged out of this in the Global Spine Journal. There are 5 studies which we examined, and all but 2 had a moderately high risk of bias, and it was not possible to pool the results in a meta-analysis. To date, the Staskis study, which I had the privilege of leading, and which we published 8 years ago, this is still the largest and most comprehensive analysis of the timing of surgical intervention for spinal cord injury. The study was done across 6 centers in North America, and we recruited 313 patients with a cervical spinal cord injury. And we found that decompression prior to 24 hours can be performed safely and was associated with improved neurological outcome, which we defined as at least a 2-grade improvement in the age impairment scale at 6-month follow-up. And this is the table from this paper showing that the odds ratio of an improvement was almost 3-fold higher. So from this line of evidence and a few other lines of evidence, we were able to provide for the first time a guideline which suggested that early surgery be offered as the preferred option for patients with an acute spinal cord injury regardless of level. But because of the paucity of the studies and the lack of quantitative meta-analysis, the quality of the evidence as rated by the grade criteria was low and the strength of the recommendation is weak. And we really need to do better than this. So there's a critical need for higher quality evidence. Does the timing influence the outcome for all forms and levels of traumatic spinal cord injury, including thoracic spinal cord injury? So what I've shown you to date has been published, and the next part of the talk will represent unpublished work, and much of this is now in press and will be published in Lancet Neurology in the next few months. So our hypothesis was that early surgical decompression of all forms of spinal cord injury would improve long-term neurological recovery. And to undertake this, one needs 4 key points. One needs a large sample size to derive precise estimates. One needs long-term follow-up, an examination of key subgroups because of the heterogeneity of the patients, and one needs uniform and validated outcome measures. So to do this, we are fortunate enough to gain access and to combine 4 large, high-quality, prospective, multi-center data sets of spinal cord injury. So one is from the North American Clinical Trials Network, NACTIN Spinal Cord Injury Registry. The second is from the study that I led, the Surgical Timing Acute Spinal Cord Injury Study, or STASCA study. The third is from the SIGEN trial that was led by Fred Geisler. And the fourth was from the National Acute Spinal Cord Injury Study 3, led by Michael Brackham. And we were able to harmonize the data sets and to extract common data elements. And we looked at acute traumatic spinal cord injury, including all levels, and the key outcome we looked at was surgical decompression. We assessed a variety of baseline characteristics, including age, sex, the mechanism of injury, baseline exam, and so on. We looked at the timing of surgery. We also looked as a secondary analysis, the administration of steroids. The neurological recovery was assessed by the ASIA or INSCI scores at 1 year. The primary analysis looked at the change in the total motor scores, and then we did a variety of secondary analyses, including changes in light touch and pinprick sensation, as well as the ASIA impairment scale grade. We undertook a meta-analysis using a hierarchical mixed effects regression analysis, which is stratified to account for clustering of patients. We used a number of fixed effects covariates to look at various key potential confounding variables, and we precisely assessed effect sizes for total motor score, light touch, and pinprick score, and we developed common odds ratios for the ASIA impairment scale grades. And then we did 2 types of sensitivity analyses. We looked at a 2-stage meta-analysis, and then we also did subgroup analyses. As a secondary analysis, we looked at time of decompression as a continuous variable, and I'll show you those results in graphical format. This is the consort diagram showing the total data set that we were able to compile and the data set that we analyzed. And so out of the 2,415 patients in the harmonized data set, we were able to examine 1,548 patients. So you're not going to be able to look at all of the points in this table, but what this illustrates is that for the most part, the late and early surgery groups were well matched. There were a few differences that we took into consideration in the analysis, and one was that a higher proportion of the early surgery, so 87% versus 80%, had early surgery versus delayed surgery, and a slightly lower percentage in the thoracic injury patients. So these are the results in table form, and I'll go to the graphs in a moment, which will show this more clearly. But the bottom line is that early surgery within 24 hours resulted in significantly improved scores for motor scores, light touch pinprick scores, as well as the changes in the Asia impairment scale grades. So shown a bit more quantitatively and more graphically, we have these forest plots. And so these are the different studies that are shown here. So NACTIN, NASCUS3, STASCUS, SciGen, and then we have the overall results. These are the forest plots. So these are means plus or minus 95% confidence intervals. For the change in the total motor score, we see that this was highly significant, favoring early surgery, and similar results for light touch score, again favoring surgery, similarly for pinprick, and similarly for the changes in the Asia impairment scale grade. So very clear quantitative results showing the positive effects of early surgical intervention. And this is shown here for the Asia grade changes in the combined odds ratios favoring early surgery. And so we see that there are higher percentages of patients that convert to Asia D and to Asia E, as well as Asia C. And this is significant at p-value of 0.002. We then did a number of sub-analyses. We looked at cervical and thoracic surgery, and we found that for cervical surgery, the effects were most pronounced for the upper extremity scores. They were improved, but just missed significance for lower extremity scores. And for the thoracic spinal cord injury patients, we did see significant improvements in lower extremity motor scores. With the subgroup analysis, we found that none of these covariates had a significant biasing effect on the results. And then these were interesting data that we modeled, looking at time as a continuous variable. So here on the y-axis, we've plotted the changes in the Asia motor score over time to surgical decompression. And we see that there's a very steep decline within the first 24 hours and starts to plateau out around 36 hours. And so this clearly shows that the changes in the neurological recovery are directly related to the timing of decompression, providing for the first time clear and direct quantitative evidence for this concept of time is spine. So decompression within 24 hours clearly results in superior sensory motor recovery, and the effects are seen for cervical spinal cord injury, where the effects are particularly seen in the upper limbs. In the first 24 to 36 hours, there's a steep and continuous decline in recovery with a delay to decompression. This supports the concept of time as spine. Now, the next question relates to what about traumatic central cord injury? And here I present this 50-year-old woman with an Asia C injury. She's got clear-cut OPLL, probably had an underlying cervical myelopathy, then bumped her cord. And is there a rationale for decompression in this patient? And does the timing matter? So this is important because the epidemiology of acute spinal cord injury is changing. And in this article on the global burden of traumatic brain and spinal cord injury, we talk about this, that neurotrauma is starting to shift from a younger age population to an older age population. And now in North America, the most common type of spinal cord injury that's seen is a traumatic central cord injury in middle-aged and older individuals. So the overall incidence of spinal cord injury is stable, but the patients are older. We're seeing more fall mechanisms and we're seeing more cervical injuries. And hence central cord injury is becoming a major public health priority. Now this is the classic description of central cord syndrome by Richard Schneider, and colleagues. And there are many aspects of the original description which remain valid, but there are some things that I would challenge. So it's true that most of these injuries are a hyperextension mechanism, often patients with pre-existing spinal stenosis, either due to acquired degeneration in the cervical spine or sometimes because of a congenitally narrow canal. And it's characterized by greater upper than lower limb weakness. But there are certain facets of Schneider's original description that I would challenge. And these are the four assumptions that I would challenge. And I'll show you the evidence which essentially deconstructs each of these points. So the four assumptions are that the pathophysiology of central cord injury involved a central hematoma, and it picked off the medially positioned cervical fibers in a somatotopically organized corticospinal tract. It was felt that the clinical course was favorable. It was felt that surgery was unsafe, should not be recommended, and that central cord syndrome captured a relatively homogeneous population of patients. So the first point is that central cord injury invokes an incorrect pathophysiology. And here diagrammatically is shown the classical theory with a central hemorrhage, picks off the medial fibers of the corticospinal tract. In fact, that's not the case at all. Hemorrhage rarely occurs, and it's usually a diffuse white matter injury that more preferentially affects the lateral tracts. And a variety of neuroanatomical studies have shown the absence of somatotopic organization of the corticospinal tract. But monkey transection experiments and physiologic experiments in man have shown that the corticospinal tract is most important for hand function. In fact, 90% of the axons in the corticospinal tract subserve hand and upper extremity function. And so in fact, that's the actual reason why the hands and upper extremities are preferentially affected. So we've deconstructed that assumption. The next assumption is that the clinical course is favorable. Patients just do great, and they all do great, and it's homogeneous. And why would you ever operate? It's not safe to do that. Well, let's look at this. So one is that the clinical course for a central cord injury is actually not very different at all from any form of an incomplete cervical spinal cord injury. And this was clearly shown in this article from our European colleagues using the EMSCI database. And here are our data. This is unpublished work, which is currently under review. My PhD student, Jatan Badiwala. And Jatan here has plotted out the course of 652 patients from the combined data set. And we've segregated out non-central cord syndrome in central cord patients, and these are individuals with an ASIA C or an ASIA D incomplete injury. And we see that the paths of recovery for upper limb motor, lower limb motor, total motor, light touch pinprick are very, very similar. And in fact, the presence of or absence of a central cord syndrome accounted for only 0.3% of the variance in the motor score. So it was essentially irrelevant. But here are these curves if you now segregate them on the basis of whether the patient is an ASIA C or an ASIA D. So in fact, the ASIA grade accounts for 40% of the variance in the motor scores. So indeed, patients with a central cord injury have the almost identical path of trajectory as any patient with an incomplete cervical spinal cord injury. So we now know that surgery, of course, is safe. Our Staskis study and other studies have shown that early surgery can be done safely and arguably has become the de facto standard of care around the world. And as I've just shown you in the previous portion of the talk, and this work is in press in Lancet Neurology, that based on changes in ASIA impairment scale grade and various motor sensory outcomes, that early surgery is favored. Now, the other assumption is that this is quite a homogeneous population of patients, and they always do great, and so on. Well, of course, this is not a homogeneous population at all. It's heterogeneous. So we have patients who are young and old. Some people do not have any evidence of spinal instability. That's the most common situation, but other people do have a fracture, sometimes a dislocation. Very often it's a low velocity injury, but not always. There can be high energy mechanisms as well. And so look at this graph. These are the 652 patients who are plotted. And these are all patients with an ASIA C or an ASIA D incomplete cervical spinal cord injury. And look at the outcomes here. They're very, very heterogeneous. And of course, the patients are different. It's a 60-year-old man with a fall, bilateral hand paresthesiae, upper limb weakness. Here's his MRI and CT, undergoes a posterior decompression, reconstruction, and it has improvement, but has some fairly significant residual issues, mainly with pain. And then here's another person who has a similar type of injury, similar type of a treatment, but has had an excellent outcome and is completely functionally independent with essentially virtually perfect. So these are very heterogeneous patients. And central cord injury, in fact, is not unlike other forms of cervical spinal cord injury. And so when one asks the question, would surgical intervention have an impact on central cord syndrome? And in fact, in theory, the impact of surgery should actually be potentially greater in central cord syndrome than in other forms of patients. And so, for example, if you contrast these two patients, so here's an individual with an ASIA C injury without a fracture dislocation due to a low velocity fall, I would argue in a patient like this, the primary injury is actually accounting for less of the deficit than the ongoing secondary injury due to the compression and the effects of the ongoing compressive pathology. Whereas in this person who has a fracture dislocation, this is a very violent injury, and the majority of the damage is related to the primary injury with a lesser effect of the secondary injury. And if you look at the window of opportunity, it's actually going to be greatest in the central cord patients. So we hypothesize that the neurological outcomes in patients with central cord syndrome are heterogeneous and are predicted more accurately by acute clinical variables and interventions, including early surgical decompression. And so we sought to evaluate the effectiveness of early surgery and to develop a clinical prediction model for neurological recovery. We did this by merging 3 large multi-center data sets, of which I've already introduced. And we used the NACTIN and the STASCUS data sets for the derivation cohort and the NASCUS-3 data set for the validation cohort. We included patients with an ASIA C or D injury, neurological level C1 to C8, and we defined the central cord picture based on a difference between the lower extremity motor scores and the upper extremity motor scores of 5 points or more. And we looked at a variety of demographic baseline characteristics, the type of treatment, the timing of injury, mechanism of injury, and time of surgery. The primary outcome point was the ASIA motor scores at 1 year, which is correlated with changes in clinical function. And we divided a prediction model, which is constructed using multiple linear regression. And the variables included in the model were defined on a combination of supporting literature as well as predetermined hypotheses. So previously published systematic reviews by our group have shown that the baseline severity of neurologic injury and the age are critical factors which predict recovery in patients with central cord syndrome. And so in our statistical analysis, we included, based on the systematic review of the literature, age, the baseline ASIA motor score, and the baseline ASIA impairment scale grade in the model. And then based on hypothesis, we looked at the effects of early surgery and the interaction terms between ASIA impairment scale grade and early surgery. And we looked at this using a stepwise variable a selection process with multiple imputation. And we did both internal and external validation of the model. This is the consort diagram, just showing the flow of patients in this harmonized data set. Now, the age of patients has increased over the years, so there was a slight difference between our derivation cohort and the validation cohort of about 10 years, so 52 to 41. Statistically significant, may not be biologically significant, but that was a factor that we took into consideration and controlled for in our analyses. So there was no evidence of non-linearity in the results, which suggests that the modeling was accurate, and there was no evidence of collinearity, which means that there was no significant interaction between the different variables. They actually were truly independent. The R-squared value for the model was 0.0648, so it showed a decent prediction. And this is the final model that was developed. So the changes in the Asia Motor Score at a year were predicted by age, by the baseline Asia Impairment Scale grade, the baseline Asia Motor Score, as well as the timing of surgery. And then there was an interaction term between the Asia Impairment Scale grade and the timing of surgery. And I'll show you that graphically in a moment, what that actually means. So here we're separating out the effects in patients who are in Asia C and in Asia D. And in patients who are in Asia C, it's a very clear-cut beneficial effect of early surgical intervention. This plateaus out, however, for patients with Asia D. We do not discern a difference between early and delayed surgical intervention, which is interesting. And perhaps it's because of a plateau effect based on the outcome measures that were being assessed. So age and baseline severity of neurologic injury are important predictors of neurological outcomes in the so-called central cord syndrome. And these are non-modifiable factors. But what's important and what's modifiable is the influence of surgical decompression and the timing of surgery. So in conclusion, the following are the take-home messages and the future directions. Surgical decompression for cervical and thoracic spinal cord injury within 24 hours of acute spinal cord injury improves neurological recovery. There is now an opportunity to revisit existing guidelines for the surgical management of spinal cord injury. Importantly as well, there are critical considerations for future directions, and there are key knowledge gaps which need to be addressed. We clearly need a personalized medicine approach to optimize care. Patients are very heterogeneous in their presentation and their outcomes, and we need to take this into consideration. A particular challenge is the elderly patient with spinal cord injury and medical comorbidities. And I acknowledge that this is one of the biggest challenges that we face, and it's not always possible to safely operate on a person within 24 hours. And we need better methods to evaluate and assess the patients with milder forms of spinal cord injury in order to discern important differences in outcome. So on that note, I'll close out my lecture. Thank you again for the privilege of delivering grand rounds this morning, and I'm certainly pleased to address any questions should there be any. Thank you very much.